Hey, it's Erin again, your favorite ER educator, and we are going to cover oxygen delivery device basics today. So first things first, we're going to look at the role of oxygen in the body. We're going to understand how hypoxia affects the body. We're going to look at some indications on why we might put some supplemental oxygen on a patient. We'll look at oxygen delivery devices, and then kind of reviewing what we've learned throughout the presentation, we'll look at 5 different case studies, and hopefully you can pick an appropriate oxygen delivery device based on that patient scenario. Now, I will just preface this by saying I am not a respiratory therapist. I am not a respiratory doctor by any means. I am not an expert. However, I do feel comfortable with the material, and so we're just going to look at basic oxygen delivery device stuff here today. And certainly if you want more education, I'm sure there's plenty of it out there for you. So first things first, we're going to look at what the role of oxygen is. So oxygen is essential for maintaining normal cellular function, and our cells use oxygen to create energy. If anyone remembers back from science class, this is like the Krebs cycle, right? You can look that up if you want more info on it. But in a basic sense, when we breathe in air, the air contains oxygen, right? And that goes into our lungs when we take a nice deep breath. Once it's in the lungs, oxygen diffuses across the alveoli to exchange gas. So then the oxygen moves into the bloodstream where it attaches to our hemoglobin on our red blood cells, and from there, our blood carries this oxygen throughout our body where it's used up by the cells and the tissues for all their essential functions. We can talk about gas exchange a little bit more, right? Because once our cells and our tissues use it up, they give us back CO2, and then we blow that off and we get rid of it through our body. We get rid of it in other ways too, but that's kind of where we have that gas exchange happening, right? A healthy person has a respiratory rate of about 12 to 20 breaths per minute. Now, some of that can depend a little bit too on health status, medications, respiratory conditions, but our respiratory rate will alter depending on those things, but a normal healthy person has a respiratory rate of 12 to 20 breaths per minute. When we think about does this patient need oxygen, some things you should consider are, do they have a functioning airway? Are they breathing effectively? And do we have adequate circulation to meet the cellular demands for oxygen? Our ABCs, airway, breathing, circulation, that is essential for ensuring proper oxygenation. And so you have to make sure that they have a patent airway, they're breathing effectively, and they've got good circulation. If they don't, then we need to think about providing supplemental oxygen. Without oxygen, we're going to become hypoxic and our cells are going to die within minutes. So if the patient needs supplemental oxygen, it's important that it's done in a safe manner with direction from the nurse or the doctor caring for the patient. Anytime supplemental oxygen is administered, you have multiple options based on the patient scenario. So we've got low flow systems, high flow systems, positive pressure ventilation, or we've got extracorporeal oxygenation, which we're not going to cover in this lecture. That's a little beyond basic. So we're just going to look at some of the supplemental oxygen devices that we have, especially ones that we're going to see in the ER, and just look at like what patients they would be good for. But like I said, it's important that if you're giving oxygen, it's done in a safe manner and that you're monitoring the patient to know if what you're doing is actually helping or potentially making them worse. All right, so let's talk a little bit about hypoxia. So hypoxia occurs when the tissues and the cells don't have enough oxygen to survive and perform their initial functions or essential functions. Untreated hypoxia can lead to organ failure, brain damage, and even death. Now, hypoxia can be acute, which means sudden onset, or it can be chronic, which develops over time. And the symptoms of hypoxia might vary accordingly, depending on if it's acute or chronic. And several factors can lead to hypoxia, such as high altitude exposure, lung diseases like pneumonia, COPD, or asthma, heart problems, anemia, certain medications like narcotics or anything that's going to suppress our respiratory system, sleep apnea, and smoking. Now, when I always give lectures on this to my nursing students, I always talk about how the first stop on the oxygen train is the brain. So one of the very first things that you're going to see if your patient is hypoxic along with shortness of breath, along with rapid shallow breathing, accessory muscles, changes in the skin color. The patient's going to be tachycardic or maybe having palpitations. And the reason that that is happening is your body is trying to speed up its heart rate to circulate extra blood because, like I said earlier, that oxygen is going to attach to the hemoglobin. So your body will actually speed up its heart rate to circulate that extra blood to get extra oxygen where it needs to go. But one of the first stops on the oxygen train is the brain. So along with tachycardia and an increased respirations, you're going to see neuro changes. So you could have cognitive changes, dizziness, fainting, headache, fatigue, weakness. Patients might be confused, okay? So watch out for your neurological signs and symptoms along with your fast breathing and fast heart rate. Patients might also complain of nausea or loss of appetite, and like I said, anxiety could be a really big one in there too. How do you diagnose hypoxia? Couple different ways. You can use a pulse oximeter. We want our oxygen to be at least 92% or higher on room air. Greater than 95 is even better unless they're a COPD patient. We could also consider some imaging studies and ABG analysis, which is a lab test. If the patient's hypoxic, then we need to think about giving them some supplemental oxygen. So what are the indications for oxygen? Well, we've already talked about some of these. So acute hypoxemia, so pneumonia, shock, asthma, heart failure, pulmonary embolism, COPD. Maybe we're going to give some oxygen for ischemia, so patients that are having a heart attack or sepsis. And heart attack treatment, oxygen isn't, it used to be that we would just slap oxygen on everybody. We don't necessarily do that anymore. It really depends on the patient's vital signs. Sometimes if there's abnormalities in the hemoglobin, so maybe the patient has carbon monoxide poisoning or sickle cell disease or other anemias. They're not going to carry that oxygen well on their hemoglobin, and so they're going to have trouble breathing, and so we're going to treat them with oxygen. Maybe if your patient has a pneumothorax, or sometimes even sedative type states, so patients that come back after anesthesia, or maybe they're using narcotics, etc. So what are some things, if you're going to deliver some oxygen, what are some equipment that you might need? So first of all, we're going to look at some non-invasive oxygen delivery devices. So that would be like your nasal cannula, your simple face mask, face tent, a non-rebreather mask, high flow, CPAP or BiPAP. Those are non-invasive. Invasive oxygen delivery would be things like intubation, so endotracheal intubation or tracheostomy. If you're working in the hospital, oxygen is typically supplied through a gas pipeline or cylinders, and in non-hospital settings, typically patients at home are going to have oxygen concentrators or potentially little cylinders too. Humidifiers are commonly used in oxygen administration because oxygen is very drying, and humidifiers help prevent dryness and irritation by adding some moisture to the oxygen. This helps with patient comfort, protects the airways from potential injury, and prevents like mucus plug growth, especially in like your trached patient. Your common oxygen monitoring equipment includes a pulse ox, CO2 monitor, maybe some ABG analysis, and then don't forget about your airway adjuncts and other supplies. So like your oral pharyngeal airway or OPA, your nasal pharyngeal airway or NPA, suction, oxygen tubing, laryngeal mask airway, which is a LMA, and then like I said earlier, your ET tube or endotracheal tube. Anytime you have a patient that needs some oxygen, just make sure that you've got appropriate supplies at the bedside and that you've got all the suction and backup airways if you potentially can't get the airway or the oxygen that you are desiring. All right, these are just some common oxygen terms. I don't expect you to memorize these by any means, but some of them are important, especially the FiO2, which is fraction of inspired oxygen. So this is the percentage of oxygen that the patient receives. So all of us right now walking around, we have about 21% oxygen in room air, right? So if you think about FiO2, that's the percentage again of oxygen that patient receives. So if we have a patient that is struggling to breathe on room air, we definitely want to make sure that we're giving them an FiO2 that's higher than that, right? And a lot of our oxygen delivery devices, if they're connected to a wall oxygen or a cylinder, you're going to provide at least 100%. So again, based on your patient scenario, that's going to kind of help dictate what delivery device you're going to pick. Your SpO2, this is your oxygen saturation of hemoglobin. This is what we measure with our pulse ox, and we want that to be 93% or higher. Now, in some patients like COPD, it might be okay that they're a little bit lower, but you need to know what their norm is. So that way, if you see like 88% on room air, you're not wackadoodled if that's kind of where they hang out. But if you have a young, healthy person and their oxygen saturation is in the 80s on room air, that's a problem. If it's 70s on room air, that's a problem too. So you just got to kind of know what the patient's norm is. Respiratory rate, we already talked about this a little bit, but a normal healthy person respiratory rate adult would be 12 to 20. And obviously based on the fact if they're an infant or a pediatric patient, that's going to vary. Obviously theirs is going to be faster. The other things on this slide are just nice to know information, not necessarily need to know as a tech or a CNA, just nice to know information. So you can review that on your own. But I do want to call out those things because it's going to make sense a little bit more when we look at oxygen delivery devices. The first one we're going to talk about is the nasal cannula. So this is tubing that runs from the oxygen source, like the wall or a cylinder, to the patient's bilateral nostrils. It's the most common oxygen delivery device. The flow rate is typically 1 to 6 liters per minute, and that's really going to be patient specific. That FiO2, it's kind of hard to measure, but it's going to be somewhere between 24 and 40%. And remember, room air is 21%, so they are getting a little bit extra inspired oxygen here. Now, some advantages. It's great for patients that are on long-term oxygen. So think about like your COPD patients, and it is pretty comfortable, but it can break down behind the ears, like break down the skin, and then on the cheeks. So sometimes people will put padding on the cheeks if this is something that they're wearing often. It's also nice because it's lightweight and it's more comfortable than a mask. People don't typically feel claustrophobic with it, and patients are able to speak and eat and drink with this in place. Now, the bummer of this is that you can't really provide high flow oxygen, and it can cause some nasal irritation, even, at that 4 or 5 liter per minute. So it's not a bad idea to do some lubrication or humidification. And then just like I said, be mindful that it certainly can dry out those nasal passages. So you got to be mindful of that. The other nice thing is some of these nasal cannulas will actually come with CO2 detectors on them also. So it's a good way to monitor your patient if they're sedated or, they just need a little bit of extra support. Next up is the simple face mask. So a simple face mask is just a mask with tubing that's hooked up directly to an oxygen source. It's very similar to the nasal cannula. However, it is delivered in a mask form over the mouth and nose instead of just the nose. On the mask, as you can see in the picture, there's holes on the side to let air flow out when the patient breathes out or exhales. Now, the nice thing about this is that the flow rate can go up higher. It's 6 to 12 liters per minute. Your FiO2 is about 35 to 50%. The things to consider with this one, the simple face mask is great. So especially if the patient is a mouth breather, this is a great option. So if you have a patient that's maybe asthmatic and they're coming in and they're mouth breathing and they can't catch their breath, this would be a good option. However, some patients get kind of claustrophobic with this, so you got to be careful with that. And it also requires kind of a higher oxygen flow to prevent rebreathing of carbon dioxide. So if the patient is breathing really fast into that mask, even though it's got the air holes on the side, sometimes they can rebreathe that carbon dioxide that they're exhaling. So it's important that you don't use this if the flow rate is going to be less than 6, because it promotes that rebreathing. So you got to be careful with that. When using the mask, you want to consider humidification to keep the mucous membranes from becoming dry. And again, it can be uncomfortable. It can interfere with talking, eating, drinking, and those chances of rebreathing CO2 are high if it's not at a high enough flow rate. Next up is the non-rebreather mask. It's very similar to the simple mask, but as you can see in the picture, this kiddo, it has like a little reservoir bag on the bottom of it. The reservoir bag, kind of where the green sticker is on the picture, it has a one-way valve which separates the mask and the reservoir bag. That prevents exhaled CO2 from entering the reservoir and only allows oxygen. So if the patient is breathing really heavy and you're worried about them retaining CO2 or rebreathing the CO2, that's not going to be an option in this case. It's going to prevent that exhaled CO2 from entering the reservoir. So the patient will only get oxygen. Now, the bag has to be inflated. And so you got to make sure that that bag is inflated before you put it on the patient. The flow rate is 6 to 15 liters per minute. Your FiO2, this one's really nice, you guys. It's 60 to 100%, and that again is because of that reservoir bag. So a nice thing about this is that it provides the highest concentration of oxygen for hypoxic patients to a patient that's breathing on their own. And again, you can get up to an FiO2 of about 95% if they're breathing on their own without having to use other machines, more invasive machines. So this is a really good option. Now I say that, but it's not a long-term solution. You may need to switch to a high flow, BiPAP, or intubation unless they can be titrated down. And again, it's going to interfere with speaking, eating, drinking, and any sort of malfunctioning of that valve can cause a buildup of CO2, and then they're just going to rebreathe that. So you just got to make sure that you're monitoring your patients and watching them at all times. Next up is CPAP and BiPAP. So CPAP is continuous positive airway pressure. It provides constant pressure of oxygen into the lungs. So when we think about settings for this one, again, you don't need to memorize these by any means, but I'm just going to run through this. But typically you have a pressure setting, and it's going to be set at 5 to 20 centimeters of water. And you want to just kind of titrate that to make sure that you're getting a pulse ox to be greater than 92%. Most people are going to start their pressure between 5 and 10 centimeters of water, but it can go up to 20. Now your FiO2 is going to be variable, and I say it's variable because not everybody hooks theirs up to oxygen. So like if you have like a sleep apnea patient, they're not going to hook theirs up to oxygen necessarily, so the FiO2 could just be that 21% room air. It certainly could be variable. There are other patients that do hook up to oxygen, so it kind of depends. Now this is great for sleep apnea, sometimes CHF patients, pulmonary embolism. As you can see in the picture, this guy has just a little nose mask, so patients that are claustrophobic or have a hard time falling asleep with a big mask on their face, that little nose tent, and I've even seen nasal prong ones too. That's an option if they can't tolerate the face mask. It's great for chronic conditions, but it might not be a long-term solution for acute respiratory failure. They may have to switch to BiPAP or intubation if the patient's status isn't improving. So, moving up a level here, you've got your BiPAP, which is bi-level positive airway pressure. So this provides 2 levels of pressure. One while breathing in, which is your inspiratory pressure, which is a higher rate. And then you get another level of pressure when you breathe out, which is your expiratory pressure, which is a lower rate. Typically, a patient on BiPAP is going to be given with an oxygen source, so you want to make sure that your SpO2 is higher than 90%. But most patients that are on BiPAP are going to be hooked up to an oxygen source. Sometimes you might see this with patients at home and they are not hooked up to oxygen. I would say 95% of my patients are always hooked up to oxygen. So your FiO2, again, it's going to be variable, but most are going to be hooked up to oxygen. So you're going to start at about 100% and then titrate down. So when you think about BiPAP, again, you're going to set your rate between 8 and 12. Most patients are going to be breathing faster than that initially, but you want to set a steady rate. So if the patient kind of fails a little bit at breathing, they can fall back on that rate. So your inspiratory pressure, like I said earlier, is typically higher. So this is a higher concentration or higher pressure of oxygen that's given during inspiration. And usually it's 5 to 20 centimeters of water. Most of the time people start around 8 to 12. It's pretty common to be at 10 when you first start out. Your expiratory pressure is just a little bit of pressure that's given during expiration, usually around 3 to 5 centimeters of water. And again, your FiO2 is going to be variable. Settings are usually given as a ratio of IPAP over EPAP, and then rate and FiO2. So this means if you are telling somebody what the settings are, you would say 10 over 5, which would be your 10 is your IPAP, 5 is your EPAP, and then your FiO2. So maybe you've titrated them down to 30%. That's great, right? You're getting closer to that room air. Advantages of this, patients that have CO2 retention, like COPD, this is a great option because not only is it going to force air and oxygen into the lungs, it's going to force air out of the lungs just to help them make sure that they're getting good gas exchange and making sure that they are exhaling what they need to exhale so they don't retain CO2 and get a buildup of that. So it forces air in, forces air out. It just gives patients a little bit more support. This is good for patients in heart failure, acute respiratory distress, and then, like I said, some COPDs, but you just got to be very careful with that. Disadvantages, you have to make sure that there's a good mask seal for this thing to work. If there's not a good mask seal, you're going to be hearing alarms till the cows come home. So you got to make sure that there's a good seal. It's, again, not a long-term solution. They might need intubation if you can't titrate them down off of your FiO2 or your pressure settings. And it's not good for those who are nauseous, or if they're altered mental status, or they have thick secretions, because that could certainly put them at risk for aspiration. Next up is high-flow nasal cannula. So this is using air and oxygen. It's kind of a blender with humidified oxygen. Now the nice thing about this is you can get flow rates up to 60 liters a minute with this. Flow rates and FiO2 can independently be adjusted to achieve that really good SaO2. The nice thing about high-flow nasal cannula is that it improves oxygenation by reducing dead space and increasing PEEP. And PEEP is that positive end expiratory pressure. So the pressure that needs for those little alveoli to stay open so you can have really good oxygenation. So the flow rate on this is typically 8 liters a minute in infants and up to 40 liters in children or adults. I have seen it go up to 60. I will say most of the time it's going to be lower than that. And your FiO2, it's connected to an oxygen source, so it's going to be 100%. Now, high-flow nasal cannula is great. It's comfortable. It's similar to like a nasal cannula. It may be a better alternative than using a face mask. We're not going to get super far into this, but it also adds a little PEEP. Again, just a little pressure just to keep those alveoli open so you can have better gas exchange. It's similar to CPAP. Again, it helps us with increased ventilation and gas exchange. It's also an alternative to BiPAP, so patients who maybe need a little extra pressure support, but they can't tolerate a mask. Patients who maybe have like COVID or an upper respiratory infection, maybe they've got a pneumonia going on, this would be another good option too. So higher flow, it's going to force a little bit of oxygen, it's going to force a little bit of PEEP to help those alveoli stay open so we can get better gas exchange. So it's a really nice option, especially for a sick patient. If you're really thinking about, ooh, do we need a little extra humidification? Do we need a little extra pressure support? Do we need a little extra oxygen support before you think about potentially intubating? Now, high-flow nasal cannula the only bummer to this one is that it has a very specific machine and tubing. So it's going to be kind of adult versus peds type thing. So you have to figure out the size and then the appropriate tubing that goes along with this, and then it has its own separate machine that you have to set up, and it's not always common. Another downfall of this is not all of our EMS partners have the capability to hook up to this. So if you have a patient that's doing great on high flow and maybe they need to transfer to a higher level of care, you got to make sure that there's an ambulance service that's able to hook up to this, or they're going to have to switch to another oxygen delivery device. But, you know, just things to consider. All right, next up is a bag valve mask. So this is a face mask that covers the mouth and the nose to create a seal. It's got a self-inflating bag, which the rescuer will squeeze air manually into the patient's lungs to ventilate the patient. It's got a one-way valve to prevent exhaled air from returning to the rescuer. And then an oxygen inlet, which allows the device to be hooked up to oxygen for optimal oxygen administration. It doesn't always hook up to oxygen, but best case scenario, you hook that thing up to oxygen and you can get a FiO2 of 100%. The flow rate on the bag valve mask is always 15 liters per minute. I have seen some people do 10, but like, what's the point, you know? 15 is where you should start. It comes in infant, peds, and adult sizes, and it's used with patients who are not breathing on their own, so they're apneic. They've got severe hypoventilation, respiratory failure or distress, or you have a patient that's in cardiac arrest and you're doing some CPR. Severe hypoventilation, that could also be maybe you've sedated somebody, you know, or they come in altered and you don't know why yet. This might be a good option. Some disadvantages of this system is that you might need 2 staff to ensure a good seal, and an improper seal can cause leaks. So it is recommended that you use 2 rescuers, one person to make sure that the mask is seated on the face properly, and then another one to squeeze the bag. But if you're by yourself, you're by yourself and you can do what you can do, right? But it is recommended that you have 2 rescuers, so that could be a disadvantage. And you really only want to squeeze this bag until you see chest rise. You don't squeeze the whole bag by any means. Just squeeze it enough to see chest rise and then let it go. If you put too much air in, you can actually overfill and put air into the stomach, and then your patient will likely vomit on you. So don't do that. All right, last up is mechanical ventilator. So we're not going to spend a lot of time on this. This is an advanced skill. But it's a great way of controlling a patient's oxygenation, so their delivery and their ventilation. These patients are in respiratory failure. They might be altered, they can't protect their own airway, they're throwing up, or they just continue to be hypoxic despite doing some sort of other alternative oxygenation. Mechanical ventilation is used as a last resort when a patient is in severe respiratory distress and they can't tolerate a non-invasive method. To be put on a ventilator, the patient will need to be intubated and likely sedated. We're not going to go too far into settings. That could be a whole nother lecture. But ventilators have various settings, modes, which control the respiratory rate, the inspiratory pressure, expiratory pressure, the flow rate, and the FiO2. So this is great with patients that are apneic, who can't protect their own airway, acute respiratory distress, severe hypoxia, or if they're just breathing so hard that you notice them start to fatigue, this is an option for them. Disadvantages, depending on the situation, some patients may never be able to come off the vent, which unfortunately is not a good long-term solution. So, you know, whenever you have a patient and they're in severe respiratory distress, it's always a good idea to have that conversation with them or their family to see if that's something that they really want to do. Because unfortunately some patients don't ever come off the vent. So along with oxygen being wonderful, it certainly can cause some complications. So infection, you know, especially if you think about a patient that's ventilated or on a vent, you know, you could get a ventilator-associated pneumonia, which isn't good, right? So we want to make sure that we're protecting our patients against infection. You could actually get something called oxygen toxicity or hypoxia. This is when we give too much oxygen. So you got to kind of make sure that you're giving the appropriate amount to each patient, and that is going to be a patient-specific number. Over-delivering oxygen can cause lung injury or what we call barotrauma. So again, you need to make sure that you're giving the appropriate amount to your patient, and every patient is different. Another thing to keep in mind is that oxygen promotes combustion. It's not combustible, but it promotes combustion. So it can put patients at risk if there is an ignition or a burning of a combustible material as possible. So you think about your patient that's hanging out in the wheelchair on a nasal cannula with a couple liters of oxygen and then they start smoking. Well, the oxygen is going to promote combustion. So as soon as they light up that cigarette, if there's an air leak anywhere and there's oxygen flowing, one thing that a fire needs is oxygen. So as soon as they light up, poof, they're going to burn their face. Not going to be good. So be mindful of that. Dry, non-humidified oxygen can cause an increase in insensible water losses, particularly at high flow rates. So you might have to increase the patient's intake of fluids. And then non-humidified oxygen can cause and create airway obstruction like mucus plugs. We already touched on that a little bit. And using cool or cold oxygen can elevate the risk of hypothermia. So you got to make sure you're being mindful of all the vital signs on your patients. All right, the last thing we're going to do is look at a few case studies. So after reviewing the oxygen delivery devices that we just talked about, I want you to pick the best oxygen delivery device for that patient, and you're going to follow along and do this on your worksheet. So case number 1, your patient was just diagnosed with COVID. They've got severe hypoxia with high oxygen needs, and they aren't going to tolerate a face mask, won't wear a face mask. So what oxygen delivery device would you choose and why? Write it on your worksheet. Number 2, your patient is recovering post-op. They're breathing on their own, but they're not awake yet. They have mild to moderate hypoxemia based on an SpO2 monitoring. So what oxygen delivery device would you choose for this patient and why? Patient number 3, the patient's obtunded, so altered mental status, not with it, unresponsive, secondary to alcohol intoxication. They're not maintaining their own airway and their respiratory rate is 8. What oxygen delivery device would you choose here and why? Case number 4. Your patient has a history of asthma. They come in acute respiratory distress. Their SpO2 is 88% on room air. Their respiratory rate is 28 a minute and they're breathing through the mouth. And you can tell they're struggling to breathe because they're using their accessory muscles. So what oxygen delivery device would you choose here and why? And your last one. Your patient is a COPD patient. Their SpO2 is 90% on room air, and they just have some mild hypoxia at baseline. So what would you choose for this patient and why? So hopefully that was just a good little review for you. Again, very basic. If you want to learn more about it, there's plenty of resources for you, but I just wanted to cover some basics just as a good refresher, just so you have an idea of what devices we could potentially see on an ER patient. And then, things to just keep in mind if we do start patients on oxygen. If you have any questions, let me know.